Hey, it's 7 p.m. Central European time, and very uh, lovely and warm regards from Izmir, Turkey. Um, Thank you for being on the platform. We are more than 80 people now, and it's very exciting because this time it's a little bit different ClubEndoSurg platform. Those who are used to this platform, they know that we are discussing a paper which has been selected by the literature review team of the ESES. But this time we made a little bit different. And with the difference, this is actually the first site of the collaboration of the ESES with the ESE. ESE is the European Society of Endocrinology, which is the voice of endocrinology in Europe. And dear Peter Kamenicky from France, he is representing ESE today, and we welcome him to our ESES platform tonight. And tonight we have a lot of interest from at least 3 or 4 continents. I really do not know that much, but even from Peru, we have attendance, I know. And we are very excited to have the ESE on our platform. I thank you, Peter, for being here with us today, with being ready for presenting a work, which is actually a work where we also have, as the members of the ESES, have took some participation in it, and we are very happy and honored about that. So we look very forward for having you here. And secondly, for those who know the concept of the ClubEndoSurg meetings, this is actually another webinar where it's a web meeting. We'd love to discuss the selected paper, which has been presented by the main author or one of the authors. So today we have Alexandra Zan, Lele Lorenta Poch, and Yannis Koutalidakis, all out from the European platform, Alexandra from Germany, Schön Klinik Hamburg, and Leire from Barcelona, and she is busy in Hospital de Nar and the University of Navarra, and Yannis Koutalidakis from Greece, Thessaloniki, from Aristotle University. So they have prepared some fruitful questions, actually, for Peter, and I took the responsibility to moderate. So I thank you all for being on this platform. Until now, we have reached nearly 100, and I'm very enthusiastic. So Peter, I will leave the floor to you, and I look very forward for your presentation, which is about parathyroid disorders, which came out of common discussion and a very fruitful work of 3 years, as far as I remember, of the PARAT program of the ESE. So thank you so much. In the name of ESES, I welcome you. I'm very honored to have you on our platform. So now the floor is yours.
Thank you very much, Özer, for this very kind invitation and even kinder introduction. I feel obviously very privileged to be invited to this EndoSurg Club webinar or web meeting as a joint initiative of SS and ESC. And obviously, I'm going to present a work that is fundamentally, essentially collaborative work and with an important participation of surgeons. So I'm going to share my screens. I hope that you see my slides. Can you see my slides? Do you see my slides? Is there?
Yes.
Okay. And maybe the pointer in red. Okay. So I work in France as a clinical endocrinologist at the Paris-Saclay University, and I'm also director of a research lab on endocrine physiology and pathophysiology, and work on the rare diseases or rare disorders of calcium and phosphate metabolism. And the work that we are going to discuss is a fruit of a joint effort of endocrinologists, but also pediatric endocrinologists, gynecologists, and endocrine surgeons, and actually started as an initiative of the European Society of Endocrinology, and was orchestrated by Jens Boleslev already in 2018 with the first workshop that actually tried to address the unmet needs in terms of research and education on parathyroid disorders. And then we had a second workshop during 2019 where I also participated. I think that Alexandra and others among you, yes, also in Amsterdam, when we tried to identify priorities, and we actually then met in the third phase of the program during the COVID to sizzle these priorities together. And we identified actually three areas in terms of parathyroid disorders that we then actually finalized and discussed in three different groups that were directed or orchestrated by Neil Dieters for hyperparathyroidism, Heidi Zilgoko for hypoparathyroidism, and Stefan Pilz from Graz for the parathyroid disorders during pregnancy and lactation. And a very important task went to Elena Zurdi, who was responsible for the preparation of different educational aspects of the programs and its dissemination. And here you have underlined the participation of different surgeons to this discussion and to this group. So Alexandra and Özer, but we also had Corina and Sebastian, and then others who also read the paper and discussed it. So the paper is quite long, but on the end you have also in forms of bullets the 33 recommendations that are all articulated as question and responses that were actually elaborated by more than 100 parathyroid experts from 20 countries. And many of the educational materials are actually still available on the ESC website. So if you want to look, you can have a look. So the first part, I would like to address some of the aspects on primary hyperparathyroidism, which is this disease where something happens in the parathyroid cells, either a genetic event or epigenetic or eventually cytogenetic event that leads to adenoma or hyperplasia development, very rarely also carcinoma, with PTH oversecretion, increased calcium concentration in the blood, and then increased glomerular filtration and urinary calcium excretion in normal cases. One of the first questions that we wanted to address was how to differentiate between primary hyperparathyroidism and its main differential diagnosis, which is FHH, familial hypercalcemic hypocalciuria, which is obviously very important for surgeons because in the second case, we should not operate on the patients. And here you can see the genetic events that are behind this disease, either mutation in calcium sensing receptor or in the signaling pathway that is activated by calcium binding to its receptor, the GNA11, GNA11 or AP2S1 molecules, both reported by Rajesh Thaker's group. So actually these molecular hits leads to different set point for calcium to regulate PTH. So you have actually repression of calcium secretion only for higher calcium concentrations, which leads to hypocalcemia. But you also have the same hit in the kidney, where actually the receptor, calcium sensing receptor, is expressed mainly in Henle's loop and is like blinded to elevated calcium excretion, calcium concentrations. So the reabsorption of calcium continues, and despite of hypercalciuria, you have rather very low calcium excretion. So this is the main differential point to differentiate between these two disorders. From the biochemical perspective, actually the calcium levels do not permit to distinguish between the two disorders, even though FHH as a genetic disease is usually associated with lifelong non-progressive hypercalcemia. So if you have the possibility to document this, that the hypercalcemia has been here since very long time and did not really progress. This is rather in favor of this disease. Magnesium concentration can be elevated, but are not very discriminating. PTH concentrations cannot discriminate between the two disorders, even though if you have PTH concentrations about twofold the upper limit of the normal, it's rather in favor of primary hyperpara. And then finally, urinary calcium excretion is the main tool to distinguish between the two disorders, where we need to calculate the calcium clearance of creatinine ratio that should be below 0.01 or 1%, which is actually equal to excretion fraction of calcium. So how do we calculate this? You know that you need to use this formula where you have urinary calcium excretion in millimoles per liter multiplied by plasma creatinine in millimoles per liter. So you need to divide the usual values given by the laboratory by 1000. And then you divide this by the urinary creatinine in millimoles per liter multiplied by plasma calcium in millimoles per liter. And this was proposed by Stefan Marx in 1992 as the main diagnostic criterion to distinguish between the two disorders, and the values in favor of HPP is if you have a excretion fraction below 1%. The problem is that if you look to patients with FHH, type 1, so due to calcium sensor mutation, or type 3 with mutated AP2S1, you can see that actually, even though that the values are lower than those of the patients with primary hyperpara, you still see a very important overlap. So in many cases, actually, the urinary calcium excretion does not permit to distinguish between the two disorders, and you need to do genetic testing, especially in younger individuals and those who have a familial presentation of the disease. So you will either find mutations in a calcium sensing receptor, as you can see here, or in the GNA11 G protein that is responsible for the intracellular signaling of activated calcium sensing receptor, or in this docking protein that is called AP2S1 that is usually responsible for more severe presentation. Second point that I would like to address is normocalcemic variant of hyperparathyroidism, primary hyperpara, which is, and this is the most important statement that I'm going to do, clearly a diagnosis of exclusion. So to state that we have primary normocalcemic variant of primary hyperparathyroidism, you need to exclude all the conditions that are actually summarized in this figure that we are going to look in more detail. And there is never a hurry to operate on a patient that has normal calcium concentration. This is probably the main statements for endocrine specialists, but also for the surgeons. Some medicaments can alter the presentation of classic primary hyperparathyroidism. Obviously, need to look at the ionized calcium. If the ionized calcium is elevated, then it's not normocalcemic, but the classic hypercalcemic variant. This is the first thing. Then if you have a ionized calcium that is normal, but you have elevated concentration of PTH, you need to rule all these conditions out. First, medications that are going to modify the presentation of primary hyperpara or lead to, eventually to normocalcemic hyperpara. For example, thiazides, thiazide diuretics, and lithium, which are the two most important ones, but also bisphosphonates and denosumab. And then we can also discuss others. You can have idiopathic hypocalciuria. So some individuals have mutations or altered functions of calcium transporters in the kidney, and they have always hypocalciuria. So increased calcium excretion as 0.1 millimole per kilogram per day, which means then that the parathyroid tissue is going to react and secondarily increase PTH secretion to maintain normal calcium levels. So this is not normocalcemic hyperpara. hypovitaminosis D, and it's important to replete the deficiency in vitamin D over 30 nanograms per milliliter, if this is possible. So if you have a hyperpara without exceeding the calcium concentration, I would say about 3 millimoles per liter. Obviously, this is a matter of discussion. And then you need to also wait for some time, and we can discuss this before reassessing the patient and eventually diagnosing normal calcemic variant of hyperpara when you repleted this. This is just to show you that we made a recent review or drug-related hypercalcemia if you're interested in this problematic. Obviously, renal insufficiency, that you need to look at the clearance of the creatinine. Malabsorption, all the patients that have, for example, bypass surgery will have decreased intestinal calcium absorption, tendency to hypocalcemia, and that's why in reactive hyperparathyroidism. Altered phosphate metabolism. This is another paper that we did with Andy Lecoq in GBMR on hyperpara in XLH patients, X-linked hypophosphatemia, which is a special disease that is linked to phosphate metabolism. And then finally, I don't see this because of the panel, so I will switch to the classical pointer so that I can put this here. Finally, the low calcium intake, which obviously also will lead to reaction of parathyroid glands. All these conditions need to be ruled out. And I would like to share with you this clinical case. So a guy of 50 years old that has a fractural osteoporosis with the bone mineral density that you can see here. And you can see that the first workup that has been done in March 2015 shows you a calcium concentration that is normal, phosphate that is normal, PTH clearly elevated, but a deficiency in vitamin D. And quite low urinary calcium excretion. So my colleague who saw this patient put him on vitamin D and reassessed 2 months later. So the vitamin concentration D is already normalized. The PTH went from 155 to 80, but is still elevated, rather elevated. And the total calcium concentration is normal, but also ionized calcium concentration is normal. So the question that we asked ourselves at that time is this a normal calcemic primary hyperpara? Is this actually a FHH because the urinary calcium excretion is quite low? Is this a secondary hyperpara due to a vitamin D deficiency? And we need to wait a little bit longer to see a decline in PTH. Or is this a resistance to PTH because the guy was quite short, but he didn't have any brachymetacarpia and brachymetatarsia. My colleague actually performed something that she shouldn't, but many of us would, parathyroid imaging, and it didn't show anything seducing. So we waited for the next workup, and you see that actually the calcium intake of this patient was low, only 360 milligrams per day, which is the half of what is, even not the half of recommended intake. He didn't have any mutation in favor of FHH or MEN1 or HRPT2, and he didn't have pseudo-hypopara. And actually, we opted for surveillance because there was not hurry. Obviously, he had his fracture osteoporosis, but vitamin D was already given. And you can see that actually 1 year after the repletion, the PTH concentration actually went to the normal value, and the calcium concentration remained normal. So what is important to stress that the apoptosis of hyperplastic parathyroid glands do not take sometimes 2 or 3 months, but really several months, even 1 year. So there's no hurry to diagnose, and I just wonder whether he would be operated on his parathyroids if the imaging would be more sexy than this. Just to state the normal calcemic variant of primary hyperpara, there are 2 hypotheses. Either it's a early stage of development of hypercalcemic variant. I don't really believe this hypothesis, and maybe, for example, estrogen deficiency in menopausal women would then reveal hypocalcemia. This is one possibility. Or the second is that there is some kind of resistance in the target tissues, bone and kidney, which are very important for the development of hypocalcemia in a patient that has a normal parathyroid disease, like primary hyperparathyroidism, but this resistance is hindering the development of classical hypercalcemia. Then very quickly, I would like to share with you this statement, which we can then also discuss further. So what is the recurrence of hyperparathyroidism after operation? Actually, this is an increase in calcium concentrations after the period of 6 months after successful operation. Before, it's not recurrence, but persistent disease. And we should not look on isolated PTH concentration without calcium, because this can be due to many other conditions that we have already discussed in relation with differential diagnosis of normal calcemic hyperpara. If there is a recurrent disease, obviously, we need to do a detailed workup with imaging, especially those techniques that are very performant as choline imaging and CT scans. And in function of what we see on this imaging, either do bilateral neck exploration or minimal surgery, but this is rather your expertise than mine. Then I would like to address this question: what are the causes of hypocalcemia after parathyroid surgery? If you operate on parathyroid glands of someone, there are two possibilities. Obviously, we are not going to address a quite frequent, moderate, and transient decrease in calcemia. But if you have a prolonged decrease over 4 days and a severe decrease below 2.1 millimole per liter, there might be two causes to this. First is post-surgical hypopara, which can be transient or definitive over 6 months. Due to PTH deficiency, and the biochemical hallmark of this is low calcium with quite low PTH level and increased phosphate concentration. If you look at the phosphate, this is an interesting marker. Or a hungry bone syndrome, which is a transfer of calcium into the bone, and which is classically associated, if you are going to assess, many informations actually are contained in urinary calcium excretion, classically with hypocalciuria, despite that you are giving actually to the patient calcium, even calcium in intravenously supplementation. So everything is going to the bone. It's usually associated with hypophosphatemia, because you need phosphate to hydroxyapatite formation, and hypomagnesemia. And then if you look at the balance of markers of osteoformation and osteoresorption, you clearly have increased osteocalcium and ALP levels and other markers of osteoformation. So in this case, actually you had severe hyperparathyroidism, and the bone is clearly demineralized, and then you remove the parathyroid lesion because you are very skillful surgeons, and you are curing the patient, but suddenly there is no PTH anymore. So PTH excess is not acting on the bone, and there is disequilibrium in favor of bone formation. The bone resorption stops, and that's why increased flux of calcium, magnesium, and phosphate into the bone with this condition. Genetic testing is obviously very important in young individuals. I'm not going to stay a long time on this. The second part of the document, and I'm going to address only 2 points because of the time, is post-surgical hypoparathyroidism. You have here the pathophysiology of the disease. So what is interesting for us, obviously, is the 75% of patients that we see as adult endocrinologists, which is iatrogenic hypopara due to injury to the parathyroid glands. It is the chronic hypo-PT is defined as persistent hypo-PT more than 6 months after anterior neck surgery. Obviously, this is something that you know because you are all experienced endocrine surgeons, but we still see in France and everywhere, I mean, also in other countries, many patients for example, non-functioning goiters that are operated by people that are not experienced, and then they create this condition. This is an important figure, and it's resuming all the conditions that should be actually assessed to try to prevent post-surgical hypopara. The preoperative assessment should obviously for anterior neck surgery should contain calcium, magnesium, PTH, and vitamin D measurements. If there is a deficiency in vitamin D, we should supply this. Then here you have the surgery that are at risk. Obviously, thyroid cancer, where you do exploration, Graves' disease, total thyroidectomy with bilateral exploration because of recurrent parathyroid surgery, and some conditions where the neck surgery is complicated, for example, obesity. And then immediate post-operative follow-up needs to address the calcium, but we also recommend immediate PTH concentration measurements, because if you have an important decrease below 5 picomoles per milliliter or more than 70% of preoperative values, the risk of hypoparathyroidism is increased. So this is an important prognostic marker. And then at long-term follow-up, obviously, all these parameters need to be addressed. I would like to address a second point in terms of hypo-PT measurements, management, and this is the emergency management of acute symptomatic hypocalcemia. Obviously, this is a very important point, and especially those of us who train young colleagues know that sometimes they are quite intimidated by the quantity of calcium that should be supplemented. So I just like to address, underscore that if you are giving to patient a calcium gluconate in one ampoule that is called 10 milliliters, 1 gram, it doesn't contain 1 gram of elementary calcium. It only contains 93 milligrams of elementary calcium, which is 2.3 millimoles. So you can imagine someone who is, for example, like me, 70 kilos, has 16 liters of extracellular fluid. If you supply 1 ampoule of calcium gluconate, that's going to do nothing. So normally the treatment of acute symptomatic hypocalcemia is 2 to 3 ampoules of calcium gluconate in 5 to 10 minutes intravenously, and then you switch, if necessary, to an infusion that is contains several ampoules of calcium gluconate. Calcium chloride contains more elementary calcium, actually the double approximately, but is going to acidify the pH. And just don't forget, if there is a hypomagnesemia that is associated, you also need to supplement the magnesium. And obviously, if the patient has very low calcium levels or altered EKG, it must be monitored in an acute emergency room. I'm not going to comment on the treatment because actually this is a business of endocrinologists. And for the remaining time, I would like to address very few points in the third part of the document that is very interesting, and for the surgeons also interesting. And this comments the parathyroid disorders during pregnancy and lactation, during which the homeostasis of calcium changes clearly. Calcium and phosphate are actively transported by the placenta to the fetus, where the gradient between the calcium concentration between the mother and fetus are actually 1 to 1.4. And this is to form stocks in the first and second trimester in the mother, but in the third trimester, we need to supplement the mineralizing skeleton of the fetus. So this transport is very important. And there is a switch in regulation of calcium, where actually not the PTH are from the parathyroid glands, but the PTH-RP from the placenta is going to be the main regulator of the calcium and phosphate homeostasis in the mother and the fetus. I'm not going to more in the details. And that's why actually we can say that both pregnancy is going to modify the clinical picture of the hyperparathyroidism, but also hyperparathyroidism potentially increases the risk of the mother and fetal complications. I have two very quick clinical cases. The first one is a lady that I've seen when she was 30, but she was actually already operated when she was 34 for a hyperparathyroidism. You can see here with ATMN1 mutation. And the surgeon found an adenoma at the right inferior parathyroid glands and normalized calcium level until 2011 when she recurred she presented a recurrence of her hyperpara. She had no complications, and we advised her a second surgery. You can see that the imaging was not beautiful, but showed a recurrence probably at the same site. But actually, she got pregnant before the surgery, and we opted for a conservative attitude because of the presentation. But she was a cashier, and she didn't follow my recommendation of abundant hydration. So she increased her calcium to 3 millimoles per liter. So then I needed to stop her from her work. She followed the recommendation of hydration very well, and during whole pregnancy actually stayed in the target values between the 7 to 8 millimoles per liter. Her calciuria, this is important, increased to 20 millimoles in the third trimester. But this is not a problem because during the pregnancy, there is a physiologic increase in calciuria, and the risk of lithiasis is actually decreased. And then she was planned for the delivery and had parathyroid surgery after the delivery. The neonate had a transient hypocalcemia that was not symptomatic. This is another patient, another presentation, 33 years old, and she was actually diagnosed because of nausea, vomiting, epigastric pain, and loss of weight in the beginning of the second trimester in another city than ours, with a very serious presentation. You can see that calcium was a 4.88 millimole per liter. Ionized calcium also very increased, PTH increased, and she had acute pancreatitis. That's why she had this nasogastric sonde. And you can see that she had a very big parathyroid lesion that was more than 3 centimeters. So obviously here the management is surgery as soon as possible. She recovered from the acute pancreatitis. She had got hyperhydration IV, and the center where she was taken care of initially even had given her pamidronate, and this is something that we should not recommend, obviously. Then she came to our center for the surgery. She was operated on almost immediately, and I would like to share with you this observation because actually the parathyroid lesion was big, not encapsulated, very nicely presented. Actually, it's not a carcinoma, but still several mitoses and Ki67 up to 15%. So it was to us atypical adenoma, and I don't know if you observed this in pregnancy. So several recommendations to the management of primary hyperparathyroidism during pregnancy. Our consensus recommended operation if the calcemia are about 2.85 millimoles per liter, and the surgery should be planned in second trimester. Before the surgery, we need to recommend oral or IV hydration. In some patients, we can use Cinacalcet if necessary. Sporadic disease can be operated by mini-invasive techniques, but hereditary bilateral disease needs to be addressed by a neck exploration and obviously a very experienced surgeon. There is a change before compared to other statements before. We can obviously use preoperative ultrasound, but also other imaging techniques such as MRI or even technetium system scintigraphy, because the risk benefit is clearly in favor of this technique. And I will stop here, and we'll be very happy to discuss with you these points and other points that I didn't have the time to raise, because actually 25 minutes and I went a little bit late, I'm sorry, is not enough to address all the richness of this paper, but I invite you to eventually read the bullets at the end. These are resuming very well also the content of the paper.
Thank you so much, Peter. Actually, as you mentioned, the consensus is it's a consensus of 63 pages. So I invite to our attendants to take a look at it if they did not do until now, because it's a very comprehensive report coming out from the ESC, and it's a group of, as I told you in the beginning, a group which was working for 3 years, including endocrinologists and endocrine surgeons. One housekeeping rule: I will take some questions, but I will take them after inviting the discussants for the questions. So please feel free to use the Q&A button to ask your questions. So the Q&A button is for your questions. Peter, thank you so much, and thank you so very much for bringing the highlights, because as surgeons we are asking always about the normocalcemic hypercalcemia, how to manage, and about the hypopara. Even we are experienced surgeons. Not everybody on this platform is experienced, but we still face. And we see that patients may suffer from it, especially the permanent cases are really troublesome. And on the other hand, how to manage a pregnant patient. And thank you very much for bringing it on this platform in this way with your cases. So it's very interesting, actually. So I'm very happy to see it in this form. You're not late. We are quite on time. Thank you so much for being keen on that. And now I'd like to invite actually the discussants. First, starting with Alexandra, because she was one of the co-authors of this very nice consensus. But I'm sure that she has some questions, even being on the consensus. Alexandra.
Yeah, Peter, thank you very much. It was a very nice talk, and I think as I said, you stated the main topics. As a surgeon, I have, of course, a question to the normocalcemic hyperparathyroidism. You always have to die one death when you are working together with endocrine surgeons and endocrinologists, and I think we get on very well all over the years. But there's still one question to me, because some of them are symptomatic. So, and I think this whole exclusion diagnosis does not really put a point on the symptomatic thing. There's a good paper of Bilisekian from 2018, and he said you have to measure the BMD every year in the normocalcemic patients, and also the nephrolithiasis, maybe make a CT to see any whatever stones. So this might be a very, very important point too, if we operate or not on them. Because I still can say we really have big centers with us. Yeah, we have big centers with osteologists, and they send the patients because they say we can't treat the osteoporosis without the operation of the adenoma. And we see this adenomas in normocalcemic patients with a normal ionized calcium.
So I think that I think that there are several aspects in your question. Your question is very rich. Clearly, I would, if there is a reason to treat, I would advocate for operation and not treating or putting the patient on cinacalcet. This is the first time. So I agree with you that to treat and to improve tissue outcomes, we better operate on the patient. Then the point on tissue complications is obviously crucial. We need to evaluate the differential diagnosis of secondary hyperpara, but we need also to evaluate the complications. If there is osteoporosis, especially in the cortical bone, and if there is a nephrolithiasis, we are going to look at the patient differently, and it's going to be also an argument of operation. Then I would just like to address or to to also mention that the etiologies of osteoporosis are many, and sometimes there are actually several. And then the etiologies of nephrolithiasis are even more, and then can be also several. So we are not necessarily going to improve the nephrolithiasis by removing a small parathyroid adenoma if someone is having a very high sodium intake and eating a lot of proteins and having concentrated urines and not drinking all over the day, etc., 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 and having low citrate, etc. You know, so it's more complex just by picking up. Well, there are complications. We are going to improve them. We need to evaluate also this practice. And as you know, in the natural history of normocalcemic variant of hyperpara, we are lacking many data. And in terms of what we are doing, we are lacking data. There is this paper by Koumakis and Catherine Cormier and Jean-Claude Souberbiel from Paris, from Cochin, which is always cited because it's one of the few papers that clearly is demonstrated that if you operate on patients with normocalcemic hyperpara, you are improving their bone mineral density. I don't know at which side. I think it's in lumbar spine. But then they're actually the bone mineral density in the forearm in the opposite direction in that paper. So it's important work, important series. It's a retrospective series with high bias. So we need more data. And I think that it's one of the priorities of the societies to work. We were working with the European Society of Endocrinology on the roadmap project together with the ESPE and normocalcemic variant or the clinical spectrum of hyperparathyroidism, especially the normocalcemic variant, is identified as one of the priority of the society. I would finish with this in the 10 years coming. So that we should produce more data.
Okay, thank you very much. And we could talk for hours, but now I have another question to another part of all this paper.
Don't frighten the participants.
You know, I don't want to. What is with the routinely PTH measurement or testing when we have a successful parasitectomy? When we did a parasitectomy, what should we recommend? Because we said in the consensus paper, maybe the PTH testing is not recommended. Why not, and why? What would you say?
So, yes. So actually, I have shown you about the neck surgery that it's interesting to measure PTH after surgery, but it was meant more about the thyroid surgery to eventually predict a postoperative hypoparathyroidism. Okay. Now, when we have an elective surgery on a parathyroid gland, what is interesting is that we have eventually the perioperative PTH and then the immediate PTH concentration, but we should not monitor the PTH itself. This is clear. And we should, in the long-term management, focus on calcemia. If the calcemia remains normal, we do not need to address PTH. Many of us would eventually sometimes look at it, but then you need to know to interpret it. But we need to send out a clear message in the long-term management of hyperparathyroidism that has been operated. You need to look at the calcemia levels. And if you have hypercalcemia that recurs, then you look at the PTH. You don't need to look at the isolated PTH, because if you have increased PTH with normal calcemia, then you have all the causes that we have actually already discussed as vitamin D deficiency, etc., that can be behind this. So you're going to create unnecessary problems.
This is very, very important. I think that came out of this paper, and we changed our recommendation, and we don't have so many readmissions since then, because doctors outside, they always think, oh, maybe the PTH is high again because of a recurrency, or and I think this when Neil came up with this idea and all the endocrinologists, I was really a bit scared, because I thought, no, you always have to measure the PTH, as a good surgeon, to see that everything is fine. But to be honest, I think this is a very good advice in this paper. No?
I think that it's interesting to see immediately after the operation the drop. But then if you cured the patient, you stated that calcium levels are low or normal, went to the normal ranges. Then for the follow-up, it's the calcium.
Just calcium. Okay. Then my last question would be, but you already answered it. What is the recommendation for women with PHPT? Or how can I say? Maybe I can say, do you think it would be a good idea for gynecologists and everyone who is in the what can I say, gynecologist area to measure at least the calcium when a woman would like to become pregnant, for example? Do you think that should be a screening test, you know, for
in all women? In all women?
No, only the ones who would like to become pregnant. You know,
I know.
Centers.
I don't know. It's an interesting question. I don't have a clear response. I don't know in terms of cost and benefits what this would actually clearly bring. I would advocate for vitamin D substitution in pregnant women. We do it in France by one ampoule of 100,000 units at week 28, or if you find a deficiency, then you substitute. I would also like to say that the first cause of neonatal hypocalcemia is still rickets, actually, also in a country like France. So vitamin D deficiency of mothers and infants because of the not enough supplementation by the mothers with newborns that have actually rickets still occur, and I have seen, and this is important. But screening for hyperparathyroidism in pregnant women, I don't think that it's necessarily frequent enough that it's actually cost benefit would be in favor of this. But on the other hand, I would be sensitive to symptoms that are symptoms of hypocalcemia, such as vomiting, which are clearly symptoms that are considered as normal in pregnancy because of hyperemesis gravidarum. And then you should not only search for hyperthyroidism, but also look at the calcium levels in these cases.
Thank you so much, Peter.
Hey, thank you, Alexandra, for your questions to discuss the issues. And Leire, I jump to you. And I know that one of your area of interest is hypoparathyroidism. So I really wonder what is coming out from you to Peter.
Thank you very much. I had a lot of questions. As you suggested, I will start by how we treat hypoparathyroidism. I think in the chat there was a question related to that. So as you know, our group, we have focus on this permanent hypopara. We follow up our 36 patients, and so I would like Peter to know what is your opinion about how to treat these patients, because we could see that there are like a kind of three groups of patients, like three syndromes, like the patient with hypopara with low but detectable levels of PTH that are quite easy to manage with calcium salts, sometimes a low dose of vitamin D, alpha-calcidol. Then there's another group with undetectable PTH that sometimes you find it really hard to manage. And then there's this small group of patients that still, they have this normal PTH, but they still need calcium supplements, like a relative hypopara. So in these patients, you have to rule out, as you said in your slides, the malabsorption and so on. But what is your regular management of these patients? Do you feel the same as we have this perception of three syndromes of hypopara?
So I think that your question is a double question, at least two questions, important. The first one is the treatment strategy, and the second one that is connected to it is actually the profoundness of PTH deficiency. So obviously those patients who have a complete aparathyroidism, so you cannot measure any PTH, are those ones who are going to be the most difficult to treat. If you have a remnant parathyroid tissue which is insufficient, it depends on how much of capital of parathyroid tissue you have, that you will be able to treat more or less easily these patients. And I clearly agree with you that some patients do need supplementation with calcium salts and especially with activated vitamin D analogs, despite concentration of PTH like 15 or 20, sometimes even 20. And you don't know why you cannot really stop supplementation because they become symptomatic and they have low calcium. But the second and the third group, for me, it's more or less like the same group. And even you know, the dichotomy, no parathyroid tissue versus some remaining, and then the spectrum in some remaining can be really very different. And what kind of treatment we should propose to them? Can I reshare my slides? I have prepared these 2 slides, which I skipped because of the time. So obviously, we should start with what's so-called conventional treatment, especially in the postoperative period. You usually do this. So you do provide calcium salt, for example, calcium carbonate, or eventually citrate where, in patients who have IPP treatment, and obviously activated faded vitamin D analogs. I usually use an alpha calcidol, which is once daily, but you also can use calcitriol or caltrol, which is administered 2 or 3 times daily, where we are going to supplement this part of PTH action. So this actually stimulation of calcitriol production and thus enhance intestinal calcium absorption. We are not going to act very much on the kidney and on the bone. In those who are then really not sufficiently controlled by this treatment, and we discussed and documented this very widely, actually largely in the consensus, what is insufficient control. We can propose a second-line therapy that is parathyroid hormone replacement therapy, where we are normally going to supplement all actions of PTH, not only calcitriol production and thus intestinal calcium absorption, but we are going to also act on urinary calcium reabsorption and thus normally decrease calciuria. But actually, we now know that we also decrease citraturia, and hypositraturia that is linked to PTH supplementation may be actually lithogenic, and this needs to be evaluated. We are going to decrease phosphate only with this treatment, and thus calcium phosphate product. And probably we are going to actually stimulate bone. Clearly, we are going to stimulate bone, but sometimes too much. And this is a case that we published in the Lancet now 3 years ago, where you can see iatrogenic hyperparathyroidism. This is just like 2 minutes after injection of the tracer. You can already see the uptake in the bones, like if it was a late bone scan. With really clinical symptoms of bone pain. And this is the same patients when we stopped PTH replacement therapy. You can see also the tracer in the vein, in the cephalic vein, but you can see the normal uptake in the heart and very diffuse scan as normal. So you can create iatrogenic stimulation of the bones and probably other things. So we need to be careful. There are new analogs coming up, very interesting ones, TransCon PTH and the product by Armolid Pharma that is called eneboparatide, with phase 3 trials that is ongoing, and we will see. But for the moment, this is what we actually have in the majority of European countries. And I would say that the first-line treatment is still the conventional treatment. Second-line therapy are the PTH and PTH analogs. Did this respond to your question?
For my question and beyond, thank you very much, Peter. My other question, because I would keep on questioning you for a long time, you know, but I will now move to how we prescribe medication. For example, patients with surgery for hyperparathyroidism, this time, a normal calcemic, the high calcemic hyperpara with high levels of calcium preoperatively, like beyond 12 So we had these cases in which after the surgery, they may come to A&E with titanium paresthesias, but still they have normal calcium. Do you think that there's a cutoff point of hypercalcemia preoperatively in which we should prescribe these patients calcium salts in order to avoid the symptoms?
So also I see 2 points in your question. Actually, we didn't really address this in the consensus of the PARAD group, but I'm working with Marie-Christine Van Tighem and European endocrine surgeons, Bruno Laurent et Eric Miraillet, on the French consensus of hyperpara for the next Congress in 2024. And actually, I was responsible for the preoperative treatment before operation of hyperpara. So I'm digging into the bibliography of this. I think that we need to distinguish between two situations. The first one is severe hyperparathyroidism or even malignant hyperparathyroidism, where the calcium levels are really increased. And now you can ask the thresholds, and this is a difficult question. I think that we can distinguish about 3.5 millimoles per liter, where patients should be probably hospitalized, get oral or IV hyperhydration, probably biphosphonates eventually, and in function of how much of calcium they have, eventually other treatments. Then we have this area of 2.8 until 3.5. And I think that it depends on the context of the patient, comorbidities or not, age or not, and symptoms, very symptomatic or not, where you need to intervene or not really. I feel that in France, endocrine surgeons are not very keen on putting patients on Cinacalcet, and it's not really my favorite practice neither. I mean, if I have someone who has like 3.3 or 3.5 millimoles per liter of calcemia and doesn't want to be operated immediately, I wouldn't do only hyperhydration, but probably I would prescribe, in this case, Cinacalcet. But I prefer to have a good, well-operated patient with someone who is going to stick on with Cinacalcet like for months or years. The preparation of by vitamin D is a second different problematics, because obviously you're going to do this in not very severe cases, usually below 3 millimoles per liter, to avoid especially hungry bone syndrome. So in less severe presentation where you have time and you can face with these kind of problems. This would be my response to the question.
Perfect. And then one last question that really intrigues me is, as Alexander was saying, the follow-up after a classic hyperpara who has been undergo the surgery. You rely completely on the calcemia, but how we do the follow-up of the normocalcemic patients that have been operated after a successful parathyroidectomy? Do we rely only on the calcium? Do we have any other criterion to indicate reoperation, suspecting any recurrence? Because I think it's really tricky.
The recurrence is first calcium. Obviously, if you have increased calcium, you look at the PTH. But in the first phase, you look at the calcium to be short.
Yeah, but in normocalcemic, you already had normal calcium. So I think it's really...
in normocalcemic, sorry. In normocalcemic patients, obviously you need to look at the PTH decrease. And eventually in the long term, if you have an improvement in comorbidities, then in those in whom you suspect recurrence, obviously you have to look at the calcium and ionized calcium, which will be maybe in the normal values. You need to look at PTH, but you need to look also at imaging techniques. Sometimes nicely looking parathyroid lesion in this difficult complex context can be probably of some help, and then and the evolution of comorbidities. So it's a different story. Yes, sorry.
Thank you very much. I won't take more questions just for the sake of time.
Thank you so much, Leila. Very interesting. We have very good, very nice questions, Peter. So I promised you actually to be online for just 1 hour, but the topic, what you're presenting is very interested, and we have interest of 130 people who still stay online, so that they are very keen, and they are very keen in asking questions as well. So if you allow me, I first want to jump over to Yannis from Greece. I know he is also very interested in the hypopara and parathyroid diseases. And let's take some questions of Yannis regarding the discussion. And then I will pass over some questions from the attendants, because there are very interesting questions, and it's very important to have you as an endocrinologist, as an experienced endocrinologist on this platform. So we are very sorry about that. Just tell us if you are spoiling you, but we learn a lot from you tonight. Okay.
I'm very happy to be. I even recognize some friends and participants from the group. Lars Rolligate is from Denmark. So it's a pleasure to stay with you.
Thank you so much. Okay, Yannis, we look forward for your questions to discuss. You're offline. Please turn on your.
Sorry.
Yeah.
Yes, I'm sorry. Thank you very much, Ozer. At the beginning, I would like to thank very much Peter for very interesting lecture and the presentation of this indeed very interesting article. But at the end, we read interesting articles, very important articles, and it is one of them. But at the end, we have questions over those articles that are already important, since we are already asking ourselves about them. But my main interest, as Ozer said, as I am a surgeon, and since we are surgeons, we are confident of our work, but at the end we have problems of postoperative hypopara that causes a lot of problems many times without knowing why so many times. But my questions is when we have patients with low calcium, we have low PTH after a parathyroidectomy. In order to diminish this hypocalcemia after parathyroidectomy, should be a certain cutoff of the fall of PTH, so that we should be afraid of a low calcium after it, and what we should administer in order to avoid this low calcium after surgery.
So you're talking about parathyroid gland surgery in this case, not. Okay. So obviously, what you expect if you worked on the parathyroid glands, especially several of parathyroid glands, is a decrease in calcium and PTH concentration, either in the lower limit of the normal or sometimes below the normal levels. Obviously, you are more afraid in cases if you have low calcium, and the more the calcium is low, the more you are afraid. Then you also need to know in patients where you have important bone involvement with skeletal imaging before the operation, that there may be also transfer to the bone compartment. So in these patients, you will anticipate that even if you didn't remove too much parathyroid tissue, the concentration will be probably low, because of the transfer to the calcium. And sometimes you even anticipate that the patient needs to go to the emergency room for supplementation of IV calcium. This is one of the important aspects. But when I don't know what is exactly the cutoff of when should supplementation of calcium carbonate and eventually activated vitamin D derivatives to be started. If you have a calcium level below the normal limit, and you have symptoms, surely. If you have a calcium just below the 2.2 and you have a symptom-free patient, then it depends how long time you can afford to stay to leave him in your department also. Now we do everything very quickly. It's probably more comfortable to let him out with some prescription of calcium carbonate and eventually 1-alpha calcidol, and then the endocrinologist is going to stop it. Obviously, we are going to stop more difficultly a treatment that is already started. But if you are below the normal level and you have symptoms, clearly, then you should start. Should you supplement patients with normal calcium in the normal low range? I would maybe wait.
Okay. And regarding the high fall of calcium, when should we administer also postoperatively magnesium? When is magnesium should be, because I have a lot of doubts about when to administer magnesium.
So magnesium hypomagnesemia is a cause of decreased PTH secretion, output from the parathyroid glands, but also of parathyroid resistance to parathyroid action. So if you have a PTH deficiency, like a relative deficiency, like suggested by Lehre, and you have hypomagnesemia on the top of it, you will have obviously conditions in which you will have more easily symptomatic hypocalcemia. That's why it's interesting to search for hypomagnesemia in this setting. And if you have low magnesium concentration, you should supplement it in these patients, clearly. So in those who have a low magnesium concentration below the lower limit of the normal.
Great. And my last question is, if we have a primary hyperpara, and we have elevated calcium and elevated PTH, but we have low vitamin D preoperatively, and we have programmed the patient to be operated. Is it useful in order to help the PTH to fall faster when we extract the adenoma to correct vitamin D deficiency? And in which concentration should vitamin D reach in order to be sure that we can go to the OR?
So this is an important question of preoperative treatment by vitamin D. Obviously, you will lower PTH concentration. We know also that if you are not in the setting of severe hypocalcemia, so if you are below 3 millimoles per liter, let's say, you can substitute without increasing importantly calcium concentrations, and you will lower PTH concentrations. For how long, it depends on how the patient needs to be operated, when you have your block timing, etc., etc. But you have seen that the apoptosis of the parathyroid cells sometimes needs months. So you're certainly not going to substitute for a very long time. If you are very in a mild setting, you can substitute for even several months. If you have like calcium like 2.6, 2.7 and variating like for this, you can substitute for several months, and then as an endocrinologist, see the patient before you address to the surgeon. The level that we are aiming at is discussed, but we are using in France, for example, 30 nanograms per milliliter, but it can be also 20 in other hands. If you have someone at risk of lithiasis, very high risk of lithiasis, besides the etiology of hyperparathyroidism, maybe you can be more prudent, but I would recommend 30 nanograms per milliliter. And the final reason is also because you are preventing the hungry bone syndrome and hypocalcemia of this because of this reason after the operation. So I would clearly, in milder cases with calcium below 3 millimoles, be in favor of substituting vitamin D.
Thank you very much, Peter. No more questions from me. And again, thank you very much for the interesting lecture. Thank you very much.
Thank you. Greetings to Greece.
Thank you, Yanis, for the discussion. And Peter, now we're jumping over to some questions. And I already told you we have very interesting questions, and they come from 4 different continents, and this is very interesting. So I take it from the bottom. The first one is about a case from the emergency room, a patient with high calcium, which has been managed with the calcium mimetics, and afterwards reaching normal calcium levels. do we still suggest surgery? So I think this is an easy question for you regarding the etiology. And what should we do when we receive those normal calcium levels? Still force for surgery?
Well, there is still the reason for the hypercalcemia. It had not been removed, so it depends who it was. But if it's someone who can be operated, there are not contraindication. That it's not against the operation, because this is also one of the reasons why we can put patients on cinacalcet. I would clearly recommend surgical removal of the enlarged parathyroid gland, either adenoma and eventually hyperplasia. Yes. I don't think that cinacalcet is a good first-line option in the majority of the patients.
Thank you. So I prefer to keep it very short with the questions and the answers. One question actually there is one appreciation from Peru, from one of our friends regarding the surgical platform. And this comes out from Yemen. Should we insist on operating on pregnant patient on the second trimester? Is the first trimester okay to operate on?
So this is something that we read in every article and in every textbook, that we should prefer the second trimester, no? And then you have the real situations, and sometimes you just need to operate them either earlier because the presentation is so severe, or especially later in the third trimester with the risk of preterm delivery, but because of the severity of the presentation. So it depends when your patient is diagnosed. If it's diagnosed early, then you obviously prefer to prepare the patient and operate in the second trimester. If not enough early, then you operate when it's necessary. And it's necessary or recommended to operate according to our consensus about when the calcemia is about 2.85. In some other centers, they would recommend certainly about 3 millimoles per liter. I try to be short.
Right, thank you. And another question related to bariatric surgery, which is very popular recently, especially here in Turkey. And some suffer from hypocalcemia, especially after parathyroidectomy or thyroidectomy. Do we have to treat them different than those who have not undergone bariatric surgery?
Treat the hypoparathyroidism or hyperparathyroidism? Hypo. So these are the most difficult patients to treat. And I would say it's not really actually the business for an endocrine surgeon. I mean, the endocrine surgeon is going to operate on the patient and do the follow-up of the gut or the stomach, but probably communicate with endocrinologists. In these patients, frequently we need to actually administer. I had one patient who was on 12 micrograms of alpha calcidol. Can you imagine 12 micrograms? Normally you administer like between 1 and 3. 3 is already a lot. So obviously this treatment was not absorbed and not working. And in these patients, we need to provide PTH replacement therapy frequently with sometimes parenteral vitamin D supplementations. So we perform injections, intramuscular injections of 200,000 units of vitamin D in a term to have substrate and PTH replacement. In many European countries, we still use 134, and then we will have the new ones. And sometimes even this is not enough, and we go from the twice daily injections to PTH pump. I have patients who receive PTH in a continuous infusion of PTH with Omnipod pump, which is insulin pump that we actually then use for PTH administration. Insulin pump for PTH administration, sorry. Difficult treatment to treat patients, but very interesting, passionate.
No, thank you.
I would avoid bariatric surgery in those who have already pre-existent hypopara, if possible. or clearly choose non-malabsorptive bariatric surgery.
Super, and that's very important to underline, I think.
Mm.
And one question from Lars, you mentioned he is one of the co-authors of this very nice work.
Mm.
And according to his experience, many pregnant primary hyperparathyroid patients can be managed without operation during pregnancy. Is there any upper limit of ionized calcium for conservative treatment? Or should we always recommend parathyroidectomy during pregnancy?
Well, we should not always recommend parathyroidectomy during pregnancy. The recommended levels or thresholds were in total calcium or albumin-adjusted calcium as a actually alternative to ionized calcium. But I completely agree with Lars that ionized calcium should be preferred if possible, and if the assessment is of good quality. So we need to respect the pre-analytical chain that should be very short, because you know that if you leave your blood drawing somewhere in the lab and you don't assess the variation of pH because of erythrocytic glycolysis, is going to completely force your results of the ionized calcium. So if the ionized calcium is performed quickly and is a routine thing in your centers, in this case, it's better to use this one because of hypoalbuminemia that we have in pregnant women. The threshold was not recommended, but I would say it's the half of the recommended threshold for the total calcium. So about 1.4, 1.42 should be considered.
Right, thank you. So this also goes to Ukraine. So this that was one of the questions of one of the surgeons from Ukraine, and he's asking, this is actually a surgery question: do you personally prefer to perform selective parathyroidectomy or ipsilateral revision or bilateral for the parathyroid gland? So this actually depends on your preference, but if you have concordant studies, I think it's a local exploration is more than enough, and it depends on you whether you're using interpretive PTH, yes or no.
Another question. Rather question to you than to me, actually, because my personal preference doesn't really mean too much. I have a dedicated endocrine surgeon who I really like very much, and the discussion is very fruitful and friendly. So this is important point. And then obviously, personally, I would prefer to have a small surgery if possible. And then there are cases as MEN1 mutations, or sometimes, for example, also some XLH patients where parathyroid surgery. I have many XLH patients, so that's why I'm mentioning these FX mutations, where you have a genetic predisposition for multiglandular disease. Then you opt for surgical exploration. But in the majority of the patient, I would go for the targeted intervention. But it's your business. That's your job.
No, it's very important to hear from you this as well. So we have to be careful in young patients. I think this is very important to underline. Another question from Serbia this time, and he thanks us for this question. After years of untreated primary hyperpara with elevated calcemia, after successfully performed surgery and normalized calcium levels, some patients still have hypocalcemia manifestation for months following surgery. Do you, and how do you treat them, and how often should we measure calcemia? So how would you manage these patients?
It's persistent hypercalcemia after
hypocalcemia, no persistent.
Hypocalcemia.
Patients who are suffering from hypocalcemia after parathyroidectomy.
Well, in this case, if they are suffering from hypocalcemia for months, more than 6 months, it's a definite or a permanent chronic hypoparathyroidism, and the treatment is the two options that I already actually have shown you, to keep it short.
Okay, thank you. Another question regarding the gold standard for radiology for localization is ultrasound and cystamebi from the first start. And the other questions, I think they have been answered. Hyperpara and okay. Okay, this is very important for us because as I told you, even being experienced, we suffer from patients with having hypopara. You mentioned about the pump, the PTH pump. How effective is it, and what is coming in the near future? Do you know
Yes.
something about it? Can you tell us something about it? Because the patients are asking us, they're asking whether it's good to be transplanted. Maybe you have heard there are some papers.
So maybe just to the localization exams, obviously ultrasound and technetium system maybe have been the gold standards. I think that in many centers now, Choline is replacing because it's just faster, because they have it already for the prostate cancer, so it's not really more expensive. This is actually what the nuclearis would say to you in France, at least. And then the interpretation is quite easier, and the examination doesn't take the time so long time as for the technetium system maybe. And then you have centers, for example, as Alexandra Zahn in Hamburg, where she's going to do herself her ultrasound in the majority of the patients, that she doesn't need to perform scintigraphy. And if she doesn't find the lesion, we had this discussion with Alexandra, she's going to look anyway at the thymus at some time. So I wouldn't like to do, there is not one strategy. It depends how many you operate and etc. I prefer to have a scintigraphy, and if I was a patient, I would like to have scintigraphy because of the ectopies, but this is a matter of preference and debate. And then the treatments, the pump is an option, but it's really for very specialized hands. Actually, my colleague Agnes Langlart was the first one who put PTH into a pump in 3 kids, very difficult to treat, with Apesset syndrome, with Airy gene mutation, 2 brothers, and the third one has a genetic hypopara also. This was published in JCNM in 2011. Then the Americans, Gordon Cutler, I think, came out with the paper in adults in 2012 in JCNM also. And since there are several other reports. We have some data in calcium sensing receptor mutation patients who are difficult to treat, but these are non-surgical hypopara. So I would say that this is the treatment options for the most difficult cases. The patients actually accept and like it, that they have a Omnipod pump in France at least, which is an insulin pump, which is the half of this mouse, like this. Sorry, are you still here?
Yeah.
I just lost the screen. Yeah, I have a screen. So it's not a bulky pump anymore, but you still need to do some manipulation every 3 days to put the PTH and the water for preparation, sterile water, into the device. So if you are enough skillful for this is a possibility. And in terms of new products that will come, we have actually 3 of them. One is for non-surgical only calcium sensing mutation. So this is not really for today, but the most important ones are TransCon PTH coming from Denmark, and there is already a phase 3 trial. So there are some countries where there is some experience already with this. For example, Heide Ziegler from Germany has patients. They try to come on the French market. Very interesting product. And the other one is the Amolit Pharma, which is a French company. And we had the phase 2 trial in France, Spain, and Hungary in Europe. Very interesting result. It's called eneboparatide, and it's a mixture of first 16, I think, amino acids of the PTH molecule, and then you have from 16 to 20 to 30, I don't know how many, from the PTH-RP, and it's agonist to the PTH receptor that it's preferentially bound to the R0 conformation, and that's why you have a different signaling, prolonged signaling, but short PK. So it should have a different profile, for example, on the bone action, but we are waiting for the data of the phase 3 trial, to which normally many of you and in your European countries could participate. It's already started in the United States and UK. So these are the upcoming options, because obviously using PTH-134, which is developed for osteoporosis in the long term, it's not completely the final option of this interesting, very fascinating, but sometimes complicated to treat disease. And I would maybe stop with this.
Oh, okay. Thank you so much. Very interesting. And we already have passed 1.5 hours, very fruitful 1.5 hours. Dear Peter.
Still more than 100 people connected. So this is, thank you very
Yes,
much.
still.
Very, very kind for
Even it's 10:30 here in Turkey. So, and I see that we have a lot of Turkish colleagues as well. And people also from the eastern part of the world. So it's later there. First of all, we'd like to thank you for being on our platform. And this is a start for the collaboration of the ESC with the ESCS. So that's why I'd like to invite people who are online to listen to the voice of endocrinology in Europe and listen to the voice of endocrine surgery in Europe. And this is what they did actually tonight. So we are very pleased to have you, very honored to have you on our platform. Another thankfulness is going to Alexandra, to Leire, and to Yannis, because they were very collaborative this week and very enthusiastic as I was actually, and I thank them very much for being on the platform and for the collaboration. And of course, a big thank you to the attendants tonight. We learned a lot from you tonight. We discussed a lot. So we had a lot of questions. We are sorry about it if we really have put a concern to you, but we learned a lot, as I told you. Thank you so much, Peter.
Thank you very much, really, for the invitation and for the fruitful discussion. Thank you very much.
Okay, then, yes, then I wish on behalf of you, everybody, a very nice evening for the rest. And thank you all for being here, and have a very pleasant evening. Bye-bye.
Ciao.
Thank you very much. Thank you very much. Good night. Bye-bye.
Bye-bye.